Hi guys, Tim Nicase here. Some of you may know who I am, some of you may not, especially those on night shift. I am the palliative care nurse practitioner here at Beaumont Trenton, and I was asked to help participate in your educational fair for this upcoming fall. And the topic that kind of we wanted to cover was how to negotiate, or not negotiate, that's the wrong word, navigate difficult conversations especially post-COVID and during COVID, it became harder and harder to have conversations with patients and families, especially over the phone. So I wanted to give you some tips and some tricks to help you with these conversations that we have with families and with patients. So I did some research and found a mnemonic that we could use so you can possibly keep that in your head and what those, what the letters stand for and what they mean according to having that difficult conversation. So I have my visual aids here. So we're going to be talking about the SPIKES model, okay, which is also an ask, tell, ask model. So the first letter is S. So S stands for setting. So we want to make sure that we choose the right setting for the patient, whether that be in the room alone with the patient, in the room with the family, or if the patient is unable to participate in meaningful conversation, they're vented, they're sedated, or they've altered mental status, or they're just lethargic or drowsy. The conversation can take place outside of the patient's room as well. Whatever setting is most comfortable for the patient or the family. So you also want to kind of prep ahead of time what is going to be talked about, because we want to keep the topic very limited to what needs to be communicated, because obviously we can go off on these side conversations and side tangents that aren't really that do not pertain to the actual topic that we're trying to convey to them. So you also kind of want to think about what you're going to say ahead of time. Read through some notes. Obviously, you as a nurse, you are not there to give a prognosis, but you can relay a prognosis that has been previously stated by the physician. So just remember, you're not there to give the prognosis, you are there to possibly communicate the prognosis and see how the patient feels about it. Another thing that you can consider during this time before you start the conversation is consider your own emotional reaction to what you're going to say. Are your emotions in check? Have you dealt with this in the past? Are you the right person to communicate this news to them? Because PTSD is very real in nursing, and if you've had a loved one or you just recently had a patient and kind of went through the same thing, you may want to defer to somebody else or ask for some help. So don't ever be afraid to ask for help from either myself or the critical care team or the attending team or even another nurse, including the charge nurse, because we're all resources for the patient and for you to help in these conversations. So that's getting the setting right. The next step is obviously the P, because in the word spikes, the next letter is P, which is patient perception, or the ask portion, number one. Like previously I said, ask, tell, ask. Okay? So in perception, we want to assess the patient's knowledge of the situation. They might already know what you're going to tell them. So not that that makes our job any easier, but it makes opening that conversation easier, and it makes the dialogue possibly run more smoothly. But if they don't know, you could consider using open-ended questions to ask about what they know. What do you know about your cancer? What do you know about your diagnosis? What do you know about what the doctor just told you? Because sometimes doctors will come in and then walk back out and the patient is very confused. And the next person that comes in is us. So we have to consider, what did they tell them? So you might also prep by asking the doctor, what did you just discuss with them? So so not just so but so you're not repeating you're not repeating yourself to the patient, because repetition can often make patients very scared, and then it's really driving it into them that they are sick, even though they already know that. They don't need to hear it over and over and over again, especially in a short period of time. So moving on to the next letter, which would obviously be I, which is invitation. So, and just to preface, this model has been used all over the country. It is a well-regarded model to help to help all healthcare professionals deal with having those difficult conversations. So, an invitation, you want to find out what the patient wants to know. Sometimes patients don't want to know anything, especially in a culture, and it can be a cultural thing as well. Certain cultures, the family chooses not to tell the patient that they have a terminal disease, as much as that might not sit right with us. We have to understand that all cultures are different, and all communication between cultures can be different. So we want to find out how much the patient already knows. Like I said, asking those open-ended questions. What do you know? Because the more they tell you, the less that you have to tell them, and be kind of surprised, and they can be surprised by that. You can also ask how much detail they would like to know. For example, do they want to know exactly where their cancer is, especially if it's metastasized? Do you want to tell them the specific locations? And like I said earlier, consider different cultures and how they might want the information relayed to them. And if you're unsure of a patient's culture, obviously that can be researched beforehand, because culture is very important, and we don't want to seem ignorant, and we don't want to seem like we are ignoring specific cultural considerations as well. So another thing that in this portion is you can ask the patient if they want to know. Sometimes patients don't want to know. They can say, I don't want to know. I know I'm sick, and I just want to continue with my life, and I want to see how it goes. And then you can also ask at this point, sometimes patients are very tired after they've heard so many things and talked to so many doctors. You can ask them, hey, do you want me to just talk to your daughter about this? Would that be okay? It seems like you might be a little tired. You might be a little overwhelmed. I'm just looking out for your best interests. But also circle back to the patient and say, whatever I talk to your daughter about, I will then come back at a better time and talk to you about. So they're not left in the dark and thinking that we're telling the daughter something that we're not going to tell the patient. I'm just using daughter as an example. And also, we want an invitation. By asking them, it shows us that we're giving them control of the conversation. We can say, do you mind if we sit down and talk? Sometimes patients will say no. And if we leave it at that and say, okay, I understand what you're going through right now. It is very difficult. I will come back later at a better time and check and see if you're ready to talk again. Because if patients aren't ready to talk, you're not going to have a meaningful conversation. It's not going to benefit you. It's not going to benefit the patient, especially if they're not in a listening mode. Some blocking things out. They may not get all the information they need to hear. So then we move on to K, which is giving knowledge. All right. So giving knowledge this is where the big portion of saying the bad news. Unfortunately, I do have some bad news for you. I just spoke with your doctor, and it is so and so. But it's important to say the bad news and then stop and allow time for the patient to think, and allow time for the patient to process before you continue the conversation. Because silence doesn't mean they don't care. Silence most of the time means they're processing. They're processing their emotions. They're thinking about, oh man, well, I had plans to do this in a year. It doesn't sound like I'm going to get to do that. But that's okay. Everyone processes things on their own times. You could have a patient who completely shuts down, or you could have a patient that says, okay, thank you. I want to, face this head on, and, let's talk more about it. We just have to be prepared for both ends of the spectrum. We want to avoid using jargon and medical terminology. Speak to someone how you would speak to someone who doesn't have a medical background. For example, I used to talk to my grandma about her Parkinson's. She didn't really understand that it was a progressive neurologic disease. You'd have to say, well, you have a sickness in your brain, or you have a brain. It's just easier to use simple terms rather than medical jargon. Because half the time, if you walk down the street and you ask somebody what Parkinson's is or encephalopathy is, they're not going to know what it is unless they've experienced it personally or they're educated in the medical field. This is also the portion where, like I said, it's the meat and potatoes of the conversation, where we do want to give small pieces of information at a time. We don't want to talk for 10 minutes and then allow the patient. You want to give information and allow time for thought and pause and reaction, and continue that until you've reached your goal of providing all the information. So pausing frequently is good. Repeating, do you understand what I just said, or do you need me to repeat that? And then also, using silence is one of the most unused ways of communicating during this type of situation. Silence doesn't mean that neither of you care. Silence can mean respect, and it allows time for reflection internally for both you and the patient. Because in this type of conversation, this is not a one-way communication tool. This is a two-way communication tool. It helps you get to know how your patient's perception is, and also what you think about it too. How are you going to continue to care for your patient after someone receives bad news or has some difficult decisions to make? So, and also really pay attention to their body language, their facial expressions. And it's always good to possibly have some tissues on hand, obviously, if the news is, because news, like any news about your health that is bad, can be devastating, okay? So our next letter, back to the letter, is E, so it'd be addressing emotions. So this is the ask number 2. So earlier when I was talking, it was ask, tell, ask. So this gives the patient a better sense of control, that they are in control of the conversation, regardless of who is giving the information. So we want to know that most of the time, someone, when they receive bad information or a difficult conversation takes place, they're going to respond emotionally, whether that be through crying, whether that be through kind of shutting their eyes or turning away from you, fidgeting. It can also be just a complete shutdown where they don't want to talk about it anymore, and that's okay, because we can return to that at a better time. So we want to also resist the temptation of trying to make the bad news better than it actually is. So giving bad news, okay, well, I've talked with your doctor, I just talked with the oncologist over the phone, he read your scan, and it looks like, yes, you do have metastatic cancer. But you don't want to then continue with, oh, but you'll be okay, or we'll beat this, or there's plenty of treatments for it. Allow the person to kind of move into those stages of grief, because grief is going to happen regardless of if a patient is cured of a disease or not. Of course they're going to move into those stages of grief, because this is life-changing. So we have to remember not to instill false hope, and this is also something that I don't just teach the nursing staff, the bedside staff, but also the residents and physicians. Do not instill false hope. You give the facts, you check their emotional reaction, and then you plan for next steps. And our last letter to complete spikes would obviously be the final S, which would stand for summary and strategy. So this is where you continue to ask how the patient feels. What are your fears and concerns at this time? What can I do to help you at this time? most of the time they will say, well, I want to talk to my family, I want to talk to my doctor more, and to figure out what our next steps are. But you as a person, you as the nurse or the vets, taking care of the nurse, whether you're the charge nurse, bedside nurse, whatever role you're playing with that patient that day, is just to provide comfort, to provide reassurance. I will be back to check on you. I will be back to talk to you about this again, or hit your call light button if you have some more questions or you want to talk further about this. I'm here. I can sit down and we can discuss your how you're feeling and figure out what the next steps are for you. So because it's important to show our compassion and our empathy for somebody who just received bad news, who just had to really have a difficult conversation with someone they may have just met for the first time that day. This is where nurses can be heroes without overstepping their boundaries of their licensure. We just have to make sure that we stay within our boundaries and continue to provide that compassionate and empathetic care that I know all of you provide on a daily basis. So what I would do after you complete kind of this difficult conversation model with the patient, whether you're revealing new information or old information, or they already knew it, make sure you communicate back to the attending physician that you had this conversation, so they don't go in and then repeat themselves. Because repetition can sometimes cause more strife in someone and more conflict inside someone's head. So using the SPIKES method, so just remember the SPIKES. I know you're watching this on a QR code right now. I'm obviously not going to be in person, but you can pick up the kind of the cheat sheet for the SPIKES method. And if you're interested in other methods and other ways to kind of have these conversations, please contact me or contact your manager to contact me, because I'd be happy to help you out in any way. So I hope this was helpful, and I look forward to working with you guys soon.